Okay, good afternoon. Welcome to the Interim Joint Committee meeting on Health, Welfare, and Family Services. This is meeting 2, and I'd like to go ahead and get started. We have a very busy agenda as always, and we will go ahead and call the meeting to order. And Secretary, please take the roll.
Senator Rocky Adams. Senator Byrd.
Present in the room.
Senator Carroll.
Present remotely from my district.
Thank you. Senator Givens. Senator Harper Angel.
Present remotely from the district.
Senator Howell. Senator Kerr. Senator Meredith.
Present in the room.
Senator Nemes.
Present in the room.
Senator Wise.
Present in the room.
Representative Bentley.
Present in the room here.
Representative Bowling.
Present in the room.
Representative Bray.
Present remotely.
Representative Birch. Representative Dotson.
Present remotely.
Representative Elliott.
Present in my annex office.
Representative Fleming.
Present in the room.
Representative Frazier.
Present in the room.
Representative Marzian.
Present in my annex office.
Representative Rayburn. Representative Gibbons Prunty.
Present in the room.
Representative Raymond.
I'm here from my district.
Representative Riley.
Present in my annex office.
Representative Sharp.
Present in the room.
Representative Sheldon.
Present in the room.
Representative Tate.
Present remotely.
Representative Weber.
Present in the room.
Representative Westrom. Representative Wilner. Chairman Alvarado.
Present in the room.
Chairman Mosier.
I'm present in the room.
Thank you.
All right, thank you. We have a quorum established and are prepared to do business. I would just like to thank everyone for being here. Thanks to our members who are remote and new to identify yourself and where you were calling in from. And I would just like to remind everyone that you should be muted unless you are speaking. And please use the chat feature to notify staff if you want to be recognized for a question or a comment. First, I would like to take a moment of silence to honor our friends, Senator Tom Buford and Representative John Bam Carney, both of whom we lost far too soon. If you would just please take a moment to remember these individuals. Thank you. And thank you to everyone for your prayers to Senator Buford and Representative Bam Carney and their families. They will be sorely missed. First, I would like to approve the minutes from our June 16th meeting. Did all members have an opportunity to look at these? Thank you. We have a motion. Do we have a second? A second. All in favor of approving the minutes?
Aye.
Any opposed? Thank you. Okay, first, we have quite a few regulations that I would like to go ahead and talk about. If there are any questions, all of these regs were sent to members for review, and we've had our staff review these. We've had conversations with various individuals, and I know that we have some folks here standing by in case there are any questions. Are there any questions from our committee members about any of the regs? Okay, see none. I would just like to say that these regs have been reviewed And I thank everyone for paying close attention to all of these regs. And thanks to the cabinet and all agencies for your work on making sure that these regs are up to par. First on the agenda, we have an overview of the Family First Act, and I would like to thank Jenna Bannon, the program director for NCSL, for being here with us today. Thank you very much. And I know that this is a big topic. I thought that starting with an overview of exactly what this is and how it affects all of us would be prudent. So thank you very much for being here, and feel free to proceed. Thank you.
Thank you. Hello, co-chairs and members of the committee. Can you all hear me? Terrific. Thank you. Let me get my presentation set up for you. All right. Again, thank you so much for having me. I am calling in from Denver, Colorado, what normally would be my office in Denver, Colorado, but I'm actually in my home office. So please excuse me if you hear a dog barking or children in the background, but thank you so much for having me today. My name is Jenna Bannon. I am a program director for the Children and Families Program at the National Conference of State Legislatures. I know that you all are very familiar with us. NCSL is the country's most trusted bipartisan organization, serving legislators and staff for more than 40 years. We promote innovation, policy innovation, create opportunities for lawmakers to share their knowledge, and ensure state legislatures have a strong, cohesive voice in the federal system. NCSL is the only organization serving all 7,383 state legislators and more than 25,000 legislative staff across the country. I think that number is amazing. We track more than 1,400 issue areas, from criminal justice to education, healthcare, transportation, and children and families. We have someone on our team who's tracking the issue on your behalf and can provide you with timely information. We also serve as the connective tissue among all of you around the country. We bring together legislators and staff from both sides of the aisle to tackle and discuss difficult problems and find solutions. We also specialize in professional development, specifically tailored for legislators and legislative staff. And these professional development opportunities are at no cost to your state. We're also a state advocate on Capitol Hill, fighting against preemption for the 10th Amendment and maintaining federalism. We have 8 committees very similar to your states. And as you know, we also host a series of meetings. We have our big legislative summit happening in Tampa, Florida in early November, and we would love to see you there. I realize that you have a really incredibly full agenda today, so I will be as quick as possible for you. I want to provide you with a summary of the prevention provisions and congregate care elements of the Family First Prevention Services Act. I'm going to provide you a really quick summary of state activity since 2018 and just touch on some of the major challenges states have faced and some of the creative solutions they're coming up with. And then I hope to answer some of your questions or get back to you if I don't have the answer. So let's talk about the Family First Prevention Services Act. So I'm going to just touch really quickly on our data and the history. There are currently almost 424,000 children, birth through 18, in the child welfare system in the nation. Over half of the children in the child welfare system nationally are under the age of 6. And there are 3 top reasons children entered the child welfare system. The top reason is for neglect. The second reason is around parental substance abuse. And the third reason is called the caretaker inability to cope. I put in this slide because it is really very timely to see how issues around physical abuse and sexual abuse, which was historically a very big reason for removing children from their homes, has declined over the past 30 years, really a significant decline. We believe this is because a rise in social media, less stigmatization of some of these issues. But one issue has remained consistent throughout. It is the issue of neglect. Over 60% of our young children, of our children both through 18, are removed from their homes because of the issue of neglect. So as advocates, we're thinking about this issue, and as policymakers, we're trying to identify what can we do to tackle the issue of neglect. More conversations were beginning around upstream strategies. More conversations were looking at what could we be doing to prevent the issue of neglect. What were the evidence-based prevention-focused strategies as a way to support families before they were fully in the system? And thus the development of Family First. So Family First was a monumental shift in child welfare funding and structures. It's a major change to child welfare funding, allowing states to use federal funds that were previously reserved for children and families in the child welfare system for preventing a family's entry into the child welfare system. This can include in-home parent skill-based programs, mental health services, substance abuse prevention. It can include treatment. Funds can only be used in this capacity for 12 months for children who are candidates for foster care and for pregnant and parenting youth. States are left to determine what constitutes candidates for foster care. Eligible services must meet certain requirements. Services must be part of a state's 5-year prevention plan, which Kentucky has submitted. It must be approved by the Title IV-E Prevention Services Clearinghouse as promising practices, which is created from an independently reviewed study and shows statistically significant results, and supported practices. So reviewing using a rigorous experimental design and has sustained success for at least 6 months after the end of treatment. So again, programs need to be evidence-based. So let's talk about congregate care. Congregate care, which is residential treatment programs that have housed hard-to-place youth. States can only receive federal funds for family-based placements, so foster care or kinship care, or qualified residential treatment programs, which in this presentation I'm going to call QRTPs. So foster homes have only 6 or fewer children. QRTPs have 25 or fewer children. So in the new legislation, they must be licensed. They must utilize a trauma-informed treatment model. They must be staffed by a registered or licensed nursing staff. They must be inclusive of family members in the treatment process, if possible, and documents the extent of their involvement. They must offer at least 6 months of support before discharge, and these placements must be reviewed and approved by a state judge. So, how are states to respond? So I wanted to share with you state activity. Right now, 25 states, the District of Columbia, and 3 tribes have submitted their plan. 11 states, DC and the Eastern Band of Cherokee Indians, Indian tribe plans have been approved. Kentucky has had theirs approved. So state legislation. So it's been really interesting to see as we over the course of the past few years, since Family First was enacted in 2018, we have seen 160 bills from 40 states and DC have introduced legislation since 2018 related to Family First. Interestingly, in 2020, we saw one piece of legislation, and I'm sure I don't need to explain why. And in 2021, NCSL has identified 36 introduced bills from 15 states and DC related to Family First. Oh, I'm going to just go back one quick thing. So states have focused a lot on appropriating funds, and I'm happy, I think you all have a copy of the legislation. So the link to all those pieces of legislation are in my PowerPoint. So you see Colorado and Ohio has appropriated funds. States have defined QRTP in statute. They have convened stakeholders in Massachusetts and Kansas as examples. They have authorized studies of available prevention services, and they have amended statutes to limit out-of-home placements. So there have been some challenges, as you can imagine, and states are getting creative with solutions. So one of the challenges is program costs. For states to draw down 4E foster care maintenance payments for a child placed with a parent in a family-based residential treatment facility for a substance use disorder, the child must be in state custody. This seems to be counterintuitive to prevention by requiring a child to enter the system before being placed. As a result, Utah is the only state that is taking advantage of these funds. And as a solution, they are using child and family team case reviews and trial home placements. So states are also utilizing multiple funding streams to braid funds for families. So Medicaid can be used to fund the parent's placement, while Family First funds are used to fund the child's placement. Also in early 2020, states expressed a problem with administrative costs when setting up their prevention contracts. As a solution, the Family First Transition Act was passed to allow states to receive reimbursement for programs that haven't been assessed by the federal clearinghouse, but assessed by the state. Identifying eligible programs has also been a challenge. The Title IV Family Clearinghouse hasn't released many assessments, and it has assessed programs differently than other institutions. So as a solution, many have turned to the California's Evidence-Based Clearinghouse for Child Welfare and SAMHSA's Evidence-Based Practices Resource Center as a tool to identify programs. States can also submit and services for review. And then last but not least, a huge challenge has been COVID-19. All of the previously mentioned problems have been made worse by COVID. In-person assessments, funding concerns, setting up new programs, you name it, it has been a challenge. So in closing, you are exercising one of the most important ways that legislatures can support the implementation of Family First by serving as conveners and building the prevention infrastructure necessary for the success of Family First. I would encourage you to access our child welfare resources at NCSL. We have a Family First summary page. We have a chart of state legislation going back to 2018, and we have experts on our team who can answer your questions. Also, we would really encourage you to stay connected with us via our policy newsletters. Our state legislature magazine just came out this month. We have a blog, we have a terrific podcast, and we have meetings and trainings practically every month. And you can follow us on social media. So again, thank you so much for your time. We really appreciate it and are thrilled to hear you talking about Family First. Thank you.
Thank you, Jenna. Great high-level presentation. I really appreciate the overview and in pointing our members to some resources. There's a lot of information that I'm sure is available, and we're going to hear now about Kentucky's implementation of the Family First. And so I think having your background will be helpful in moving forward, and we'll just obviously come back to you if we have any questions. And
Please do.
I'm sure that a lot of our members will see you at the meeting in November in Tampa.
Please come find me. I would love that.
Perfect.
Yes.
Perfect.
And I will stay on. I'd like to listen in and be happy to answer any questions.
That would be great. Do we have any questions from our members at this point, or shall we move on to Kentucky's implementation? Senator Berg?
Thank you, Chairwoman. One quick question. In Kentucky, do you have to be in the state system at this point?
I believe so. We are going to hear about
Okay.
Kentucky's implementation next, so I think that's probably the more appropriate spot to get that question answered. So, all right, thank you. Anyone else? Okay. Representative Fleming?
Thank you, Chairman Mosier. Just a really quick question. In your first slide or second slide, you had 3 decades of trends that's occurred nationwide, and one was the sexual abuse, and that seemed to be going down significantly. But I've been hearing, and I'm in the mental health field, and I've been hearing and seeing a lot of increase in sexual abuse recently, given the COVID. Are you seeing an uptick in that nationally as well?
I have not looked at that data point, so I'm not able to answer your question at this moment. I'd be happy to take a look at it and get back to you. I also think that's a quick question for your next speaker, specifically to Kentucky, but we will definitely take a look at national statistics.
Okay, thank you, ma'am.
Thank you.
Okay, thank you. Next, I'd like to invite Kristen Bell, the Executive Advisor for the Department of Community-Based Services for the Cabinet for Health and Family Services. Please make yourselves comfortable and just introduce yourselves for the record, and please proceed.
Thank you. I'm getting our PowerPoint set up real quick. Good afternoon. My name is Laura Began, and I'm with the Department for Community-Based Services. Thank you very much for having us here today. We are very grateful for the opportunity to present. I wanted to talk to you here today. Although Kristen Bell is on the schedule as next, we're here to present on 3 different topics. So our presentations will all flow together. These may seem like unrelated topics. We are presenting on federal funding DCBS has received, a brief update on child care, and a more in-depth look at Kentucky's implementation of Family First. Something that, and again, I would submit to you that they are all very interrelated. Something that we talk a lot about at DCBS and that you've heard a lot about is the number of kids in out-of-home care. But I'd like to explain what that means. Right now, there are over 9,000 children in Kentucky who have been removed from their homes, taken from their families. The large majority of those cases had substantiated findings, that means cabinet findings, of neglect, like Ms. Bannon mentioned. And I do want to say that also with her presentation, which was a great look at Family First, we really need to tie in Family First with neglect. Kentucky was a leader in the nation implementing Family First as early as we possibly could, implemented in October of 2019. That was less than 2 years ago, but DCBS really grabbed hold of Family First and ran with it. We have built many programs since then, looked to expand it, and we look at child welfare through a Family First lens, prioritizing prevention rather than focusing on our response after maltreatment and trauma has occurred. So back to this neglect issue. Actually, in Kentucky, sexual abuse, physical abuse make up about 5% of our substantiated findings. So again, large focus on neglect. That means for a large number of these 9,000 children and their families, they needed some form of help before a child was removed from their care. Now, neglect can look like many issues. It's a complex issue, but maybe those families didn't have access to safe and reliable childcare, or maybe they couldn't afford it through programs like the Child Care Assistance Program. Some of those families might have had issues keeping the lights on, keeping the heat on through winter, or purchasing groceries for their family, and they could have received assistance through safety net programs like LIHEAP and SNAP. We know that substance use disorder has devastated many Kentucky families, but we are going to talk to you about the START program, and maybe that program can help more families and be expanded to have greater impact and help bring down that number of kids in out-of-home care. DCBS is doing everything that we can to support families and keep families together when it is safe to do so. With that, I will turn it over to my colleague, Misty, to introduce herself and talk about some of the federal funding that we have received for some of these programs.
Hi, I'm Misty Simmons. I'm the DCBS Division of Administration and Financial Management Director. So I'm going to talk about the funds that we have received from the American Rescue Plan Act. The first that I will talk about is the community-based child abuse prevention. We received $3.4 million. Those funds will be obligated by September 30th, 2025. The plan is to utilize the supplemental funding to provide additional services and supports to families across the state by decreasing community collaboration for children programs wait lists. And then we received $1.3 million for the Child Abuse Prevention and Treatment Program grant. Those funds also have to be obligated by September the 30th of 2025. Planning is underway to develop an alternative response model and implementing a structural decision-making model for intake, safety, and risk assessment in child maltreatment investigations. We received $61.6 million in LIHEAP funding. Those funds have to be liquidated by September 30th of 2022. We will continue providing the utility payment assistance program that we've done to continue a year-round program for that using those funds. We received $8.2 million for a low-income household water assistance program. Those funds also have to be liquidated by September 30th of 2023. The state plan has not been submitted, but once it's submitted, we'll have to wait for approval from the federal level to utilize those funds. The goal is to mirror the way the LIHEAP assistance program works and be administered through the Community Action Kentucky in all the states. And then we received $17.4 million for TANF. Those will be liquidated by September 30th of 2022, and we will be doing a one-time payment that will be distributed to existing KTAP and kinship cases for eligible members. So at this time, I'll turn it over to Sarah Vanover to discuss the funding that we received for childcare through the American Rescue Act. And I'm going to switch places with Krista, so she'll be ready to take over.
All right. Thank you very much. I'm Dr. Sarah Vanover. I'm the Director for the Division of Child Care at the Cabinet. We have been so blessed to receive large amounts of funding for the child care program throughout Kentucky in order to help rebuild child care, but also to help create new infrastructure that the child care system has never had before, because child care as a business model is not really set up to support itself. It's a very unstable program. So total, we've been given $763 million in this newest round of federal funding through the American Rescue Plan. That funding is coming to us from two different sources. The largest portion of the funding, $470 million, is being given to sustainability payments to child care programs that were open prior to March 11th, 2021, when the bill was passed at the federal level. We are going to be breaking that up into 9 payments to go to child care programs that are regulated in some way by the state, whether that is a licensed center or a registered or certified family child care home. Now, at the same time, we were also given money from another bucket, from the Child Care and Development Block Grant funding. These are one-time funds. Typically, we get annual funding from the Child Care and Development Block Grant that really goes to support families who are at risk, providing subsidy for child care programs, as well as our monitoring programs through the state, our National Background Check Program, and quality initiatives. This one-time funding has a slightly different purpose because it is going to all child care programs in some way. It's open to not just families who are at financial risk. There have been a lot of rules and regulations placed on this money, as there should be, for being accountable for this large of a sum. But the four main points that go along with the $293 million are to increase provider payments, increase payment policies, improve those policies, increase wages for our child care providers throughout the state, whether they work in a center or in a family child care home, to make their wages more encouraging for people to come to the field and to be able to support themselves working full-time in the field of child care, and also to build the supply of child care for underserved populations. Not only does that include families living in poverty, but families living in rural areas, infant and toddler care that may not be accessible in some parts of the state, children with disabilities who have a harder time finding supportive child care settings, as well as families living in homelessness or other stressful situations. Now, we're going to Kristen next. Okay, go ahead.
Good afternoon. I'm Kristen Bell. I'm an executive advisor with the Department for Community-Based Services, and I'm going to provide an update on our child welfare prevention services. I really appreciate the presentation by Ms. Bannon. It was a wonderful overview of the Families First Prevention Services Act and a great jumping off point to update on Kentucky's progress on implementation of those requirements. So this slide depicts that Family First, although we normally talk mostly about the impacts to our prevention services, it depicts that it really did have impacts across our entire child welfare continuum, from prevention and family preservation to kinship care. It provided requirements and funding for kinship navigator programs for the states. It also impacted foster care by establishing the requirement for model foster home licensing standards. It impacted congregate care, as Ms. Bannon shared, by implementing the requirements for the qualified residential treatment programs or congregate care residential treatment providers, by establishing that states must ensure that their congregate care providers meet those qualified residential treatment program requirements in order to request reimbursement from the federal level. And it also made provisions that impacted and established greater benefits for our youth aging out of foster care. So it extended the age to age 23, for which youth could take advantage of Chafee aftercare services. So it really did have impacts across our entire continuum of child welfare services, but perhaps the most significant impacts were to our prevention services. So as Ms. Bannon said, the Family First Prevention Services Act was enacted in February of 2018. It was a significant shift in the way that federal funding works for child welfare services. It allowed states for the first time to use federal Title E funds for evidence-based practices delivered to candidates for foster care. So in other words, to provide services to families to prevent entry into care, when historically those Title IV-E funds were reserved for services to fund services for out-of-home care and adoption. So state funds also have to be available to support prevention services under Family First. It is a 50% federal reimbursement, so there have to be state funds available to cover that other 50% that is not reimbursed by federal Title IV-E funds. States could implement as early as October 1st, 2019, but all states have to comply by October 1st of 21. Kentucky really wanted to be a leader. We knew that our prevention services were effective in our state and they were really helpful to families and children. And so we wanted to take advantage of the opportunities offered by Family First to expand those services. And so we chose to be a leader and implemented October 1st of 2019. This next slide is really similar to one of the slides that Ms. Bannon presented. This is a map that was created by Casey Family Programs that shows the states that have approved 4E 5-year prevention plans. And so Kentucky was one of the first handful of states that implemented in 2019. And still today, as of the end of May, one of only 12 jurisdictions that have an approved plan that includes 11 states and the District of Columbia and the Eastern Band of Cherokee Indians. So even though we are a full 2 years into what was the earliest implementation of Family First, Kentucky has seen the benefit of 2 years of that services, while many other states are still seeking to have a 4E prevention plan approved. Our prevention services that we're going to talk about today really fit intrinsically with the overall vision and goals of building a 21st century DCBS and the 5 pillars that comprise that vision of a 21st century DCBS. So it includes impacts on equity, so looking at racial disparities, certainly an impact in terms of addressing poverty by providing economic support. It impacts on trauma and resilience. Families certainly and children avoid the trauma of removal from the home and entry into the child welfare system with the provision of these prevention services. And mostly it impacts families, children, and youth. We know that children grow up healthier when they have the opportunity to stay safely in a healthy environment with their families and in their own communities. It also impacts on the health and wellness pillar. The evidence-based practices under Family First provide services for mental health, substance abuse, and for families who have the need for in-home parenting skills. This slide shows the evidence-based practices that are included in Kentucky's 5-year prevention plan that has been approved at the federal level. And so there are 3 domains under which services or evidence-based practices can be provided, and those are mental health, substance abuse, and in-home parenting skills. The array of evidence-based practices that you see here and that are included in our 5-year plan ensure that families across our entire state, regardless of their geographic location, have access to the evidence-based practices or services that they need to meet their needs, regardless of the age of the child, regardless of their location, and regardless of which area of need they may have, or if they have more than one. In addition to the evidence-based practices that you see here, Kentucky has also already submitted an amendment to our 5-year prevention plan to the federal level that is currently pending approval. And in that amendment, we have added high-fidelity wraparound as an evidence-based practice for which we are seeking approval at the federal level. We believe that high-fidelity wraparound is an evidence-based practice that will serve us well in Kentucky. It's effective with diverse populations. And really helps to meet the needs of families by providing a comprehensive approach to ensure that they have access to all the services that they need when they need them. The Kentucky Strengthening Ties and Empowering Parents, or K-STEP program, is probably a program that you've heard of. It was developed and expanded here in Kentucky. It is included under our Family First prevention services, so it is not included by name, but on that previous slide, you will see motivational interviewing and parent-child interaction therapy. These are 2 evidence-based practices that are used in the K-STEP program and model. K-STEP began in Kentucky in 2017 in only 4 counties in our northeastern service region. It was part of our Title IV waiver demonstration effort. We expanded to serve 4 additional counties at the beginning of state fiscal year 2020 and to all 15 counties in our northeastern service region by the end of state fiscal year 2020. In state fiscal year 21, we expanded to 3 counties in the Salt River Trail service region. In state fiscal year 2020, K-STEP served 202 families, including 380 children. And at the time of closure, 93% of those children remained safely at home with their families. So that's 356 children that avoided entry into care because of the services provided under K-STEP. Our family preservation program is also equally successful, and that represents in terms of numbers, the majority of the services that we are providing under Family First. Our family preservation program includes all of the evidence-based practices that you saw under the previous slide, with the exception of our START program. That is a separate program altogether, and with the exception of multi-systemic therapy, which I'm going to talk about in just a few minutes, but also there is a presentation later on the agenda today. So in state fiscal year 2020, FPP served 2,762 families, including 4,999 children. Of these, 93% remained in the home at the time of closure of those services, and 92% of those children were still in the home 6 months after closure. So overwhelmingly, we are demonstrating that those results and the impact of that intervention is sustainable in terms of children remaining safely with their families. So if not for the availability of these FPP services, 4,665 children potentially could have entered our out-of-home care system if those services had not been available. An expansion of 25% of our FPP program was planned for state fiscal year 2021. We are still waiting for the final reports from our contracted service providers, so I don't have the data about the number of children served in state fiscal year 2021, but we should be able to provide that very soon. The goal of our FPP program and our expansion of Family First services is to ensure that there is no waiting list for FPP services anywhere in our state. So the total impact of our prevention services under Family First, including our START program in state fiscal year 2020, was 3,367 families served. That includes 6,132 children. 5,706 of those children remained in the home at the time of closure of those services, and the percentage of effectiveness across all of our Family First prevention services is 93%. One of the ways that we want to look at the success of our intentional effort to expand prevention services is in our out-of-home care numbers. We would expect to see that if our prevention efforts are successful, that our out-of-home care numbers are going to go down. So obviously we are never going to be able to tease out any potential impacts of the pandemic during our first year of provision of Family First prevention services. But I did want to mention one other thing that really significantly impacts our out-of-home care numbers over the past 2 years that we need to take into account when we are trying to consider the impacts of our efforts around prevention. So in April of 2019, the Cabinet rolled out a new relative service array that created a new foster home type, a child-specific foster home type, and also made the process for approval as any other type of foster home much easier for relative caregivers. Prior to April of 2019, it was most common if a relative was identified for a child for that relative to be given custody directly by the courts of that child. And so those children were not reflected in our out-of-home care numbers. So I wanted to share some data around our relative placements. This number that you see on the end of this trend line, the 9,122, in June of 2021, 1,408 children were placed with relatives. That is included in that number, so that's 15.4% of our out-of-home care population as of June 2021. If you subtract that from our total population, that would leave 7,714 children in foster care if you exclude those placed with relatives. So you can see that that almost identically matches our lowest point over the last 6 years, which was September of 2015. There were 7,711 children in out-of-home care at that time. Only 275 of those were placed with relatives, or 3.6%. So this is the right thing to do, obviously, for relative caregivers, for fictive kin caregivers, and for families, and for support of those children children, and we want those children in our out-of-home care population if those children and families need those supports. But I think it's an important consideration when we look at the impact of our prevention services that we're taking into account that we had a significant shift in practice whereby we have more children in care placed with relatives, and so it's impossible to compare 2021 numbers to 2016 numbers and be comparing like things. The next slide shows our prevention expenditures versus our out-of-home care expenditures. This is another way that we can look at possible success with expansion of our prevention services. You can see that in state fiscal year 2019, we spent just over $15 million on prevention services that now fall under our Family First array of services. And during that same state fiscal year, we spent almost $411 million on out-of-home care services. In state fiscal year 2020, we spent almost $22 million, so an additional $6.5 million investment in prevention. And as a result, we saw an almost around $15 million reduction in our out-of-home care costs. So our total out-of-home care costs in state fiscal year 2020 was $395,998,000. And so remember that we did not implement Family First until October 1st of 2019, and that first quarter rollout was a little slow, so we didn't have the full impact of a full year of services during state fiscal year 2020. It was too late to update this presentation, but we have just gotten our rough totals from state fiscal year 21. In state fiscal year 21, we spent $368,328,114 on out-of-home care. That represents a $27,670,000 deduction or reduction over the previous year. So more than $27 million less spent on out-of-home care cost. We spent on prevention $24,906,000. So we invested another $3 million in prevention and saved almost $28 million on out-of-home care cost. One of the things that I will mention related to those out-of-home care costs is that it's impossible to draw a straight cause and effect. There are a number of factors that go into those costs. So one of the things that I want to mention is that in this past state fiscal year, we did also implement the Qualified Residential Treatment Program requirements, and we have seen a significant reduction in the number of children in congregate care settings. So we are seeing more children remain in family-based and community-based settings. As of this month, we have 724 children in residential. Just a year ago, we had July of last year, we had 861 children in residential. So we've seen a 16% reduction over the past year. And if you go back to July of 2019, we had 955 children in residential, which is a 24% decrease over the past 2 years. So these obviously are our most costly out-of-home care services. So when we reduce the number of children of those in those higher level settings and more costly settings, that's obviously going to impact the out-of-home care expenditures as well. So this next slide shows what I think we all know, that old saying that an ounce of prevention is worth a pound of cure. We certainly see that in our expenditures. A small investment in prevention certainly saves a lot in terms of the cost of services after children come into care. But I think what is even more impactful that we need to think about, and what I can't show you on a bar graph, is what we have saved those families and those children in terms of avoiding the trauma of removal from their homes, from their friends, from their schools, from their communities, and everything they know. And that I can't show you, but that we know is the more significant impact of what we're doing. I want to talk real quick. We use these words a lot in child welfare about primary, secondary, and tertiary prevention. So I wanted to talk just real quick about what we mean when we say those words so that everybody has the same understanding. So we divide our prevention efforts into 3 categories. The first is primary prevention, and these are activities that are directed at the general population. They're available to everyone. And so all members of the community have access to these services. So you can think about some of the activities of Prevent Child Abuse Kentucky. So some of those awareness activities about child abuse and child maltreatment. You can also think about what Sarah discussed previously. The availability of high quality childcare is a primary prevention effort and important in ensuring that children are safe and that families are healthy. We also have secondary prevention activities. So these are programs that are aimed at children and families where there is a risk factor, but providing services before any type of maltreatment has occurred. So you may think about a HANDS program, a home visiting program like that most people are familiar with. It also could be high school programs for teen parents that provide basic parenting skills and supports for those parents who may have a higher risk for future child maltreatment. Or also think about respite programs for parents of children with special needs. Those are all secondary prevention activities. And then we have tertiary prevention. So tertiary prevention is when something has already occurred. The cabinet has gone out and done some type of assessment, and perhaps there's a substantiation, but the assessment doesn't indicate that there's an immediate safety concern or that child needs to be removed from the home. So services are provided to ensure that there's not future maltreatment and to ensure that that child can stay safely in the home. So that is a tertiary prevention. And that's really what most of our Family First Prevention Service activities is tertiary prevention. And so I think this is a really nice depiction of how we can conceptualize primary and secondary and tertiary prevention. So that bridge that you see upstream is primary prevention. If everyone had access to that bridge and could get across that stream, no families or children would ever be in danger of going over that waterfall. That picket fence that you see across the stream, it's intended to stop, the children or families who may be in the water, who may be at risk of going over that waterfall. But they're already in the water at that point, and it may save them from the ultimate danger, but there's already some risk there. And there you see the net and an ambulance at the bottom of that waterfall. That's after something's already happened. So we're getting involved after something has already occurred. And you can see that the cost of providing those services increases the further we get. And right now we're really spending most of our time at the bottom of that waterfall. And that's really in large part because that's the way our funding streams are structured at the federal level. So I want to talk a little bit about our expansion of investment in prevention services. So with the additional $20 million that was appropriated out of this most recent legislative session, for which we are greatly appreciative, it will have a significant impact on the types of services and the quality of services that we can provide for families. It will be used in these major ways. We are going to expand our family preservation program services by an additional 25% in state fiscal year 2022. We also have a planned expansion of K-STEP. K-STEP is a program that in some ways is similar to the START program, with which many people may be familiar, but K-STEP has proven very effective in the rural areas of our state. And so that is a majority of the families that we serve. With this expansion, we are going to expand to the remaining counties in Salt River Trail and 3 counties in our Cumberland service region. The very long-term goal is for K-STEP to be available in all parts of our state. We also are going to increase our flex funds for families. So research shows that with some minimal economic supports, it results in less incidents of neglect, less referrals to the Child Welfare Agency. In those Family First Prevention Services, there's a very small amount of flex funds available for families. Right now, the maximum is $500. We want to increase those flex funds to $1,000. Now, that doesn't mean that every family gets $1,000. $1,000. The contracted providers who assess those families and work with those families to provide services in their home make a determination as to whether that family has some type of barrier, whether it's a needed car repair, whether it's, assistance with that month's rent. If there's some significant barrier, those funds are available. Most families actually do not utilize those funds, but for the families that do, the difference between $500 and $1,000 can be really significant, especially if you're talking about something like a car repair. We also are piloting multi-systemic therapy in 3 areas of our state. So we have partnered with 3 of our providers to pilot this evidence-based practice that is targeted at providing intensive services to some of our most high-risk youth. So these may be youth who are dually involved with our department and with the Department of Juvenile Justice, or who have really high-risk behaviors. And I know I won't talk a lot about that because I know there's a presentation later on the agenda, but that is an important investment that we're making in this next state fiscal year. And then finally, to establish learning collaboratives to increase the capacity of our providers of these evidence-based practices, to provide those, to train new staff, and to ensure fidelity to those evidence-based practices. And then finally, we talked a little bit about primary and secondary prevention. We also are making some additional investments in that area. In addition to the additional state appropriation, we also have additional funding under the Community-Based Child Abuse Prevention Federal Funds, or CBCAP. That CBCAP money, it's a very small pot of money, and it is limited to use for primary and secondary prevention. It cannot be used to serve families who are already have children in the child welfare system. But we do want to use a small portion of that money and combine it with CBCAP funding to start some community response pilots. So you may be aware that less than 50% of the calls that come into our agency receive any type of action or intervention from our agency. They don't meet the statutory criteria for us to do anything, and nothing really happens with those families. So we would like to start community response pilots that intentionally connects those families to a community-based provider, like a family resource youth service center that reaches out to that family, assesses their needs, and connects them to the resources that they need to meet those needs. We feel like that would prevent future calls to the agency or prevent challenges from escalating to the point that the next time a call comes in, it does meet criteria for the child welfare agency to get involved. We also want to invest money in expansion of parent engagement meetings. These are in a couple of counties in our state already and have been extremely effective. And so these are services that are targeted at families who are at risk of educational neglect. They are very successful in keeping those families from becoming child welfare involved. We also want to increase our in-home service provision under community collaborations for children. CCC is available in all parts of our state. It is community-based, and it is also it's secondary prevention. So it is aimed at those families where there's some type of risk factor, but maltreatment has not occurred, and it prevents those families from becoming child welfare involved at a later date. We also want to increase the client assistance funds under CCC for the same reasons that I just mentioned about the flex funds. There is a lot of research that indicates that the provision of a small amount of concrete support can really prevent families from becoming child welfare involved. And then finally, we have created a prevention collaborative. We know for these prevention efforts, especially primary and secondary prevention, to be effective across our state, that we can't sit in Frankfurt and figure out what's best for every child in every community. We really need these efforts to be community-based and to be youth and family-driven. And so we have created a prevention collaborative that allows our community-based partners, stakeholders, youth with lived experience in care, and birth families to come together to really work with us to put structures in place in every community in Kentucky that will get at these primary and secondary prevention efforts that are so important, so that hopefully families won't have to become child welfare involved in order to get services that they need. And with that, we'd be happy to take any questions.
Okay. Wow. What a presentation. Thank you. I know that we've combined a lot of these topics into one talk, and so we do have some questions from members. I have a question about back on slide 15. You talk about the cost of the prevention versus the out-of-home care expenditures. And boy, those are drastic increases. And so my first question about this is, are those first numbers, the 15 million and 21 million, are those inclusive of both out-of-care expenditures previously and residential treatment? And then, how is this sustainable is the second part, but if you could just expound upon that.
Sure. So the expenditures that are included in the blue columns in the prevention services, those are only our prevention services that now fall under Family First. So those are our START program, our K-STEP program, and our family preservation program. So it's all of those programs that fall under Family First. It does not include CB-CAP. That is just for primary and secondary prevention. The red expenditures are all of our out-of-home care costs. So those are payments per diems to our DCBS foster homes, our private agency foster homes, and our residential facilities. So it's all of our it's cost for care. It's not including the cost for our DCBS staff. It's actual expenditures for care of children who are in the out-of-home care population.
Okay. And so are these, it says 2019, 2020, so these are not exclusive to Family First provisions?
No, but what we did for the 2019, we included only those programs because a lot of those programs were existing. So we already had a family preservation program, we already had a START program, we already had K-STEP. Some of those programs were not utilizing the evidence-based practices that are now included under our 5-year prevention plan, but we only compared like programs. So the programs that now fall under Family First that you see in state fiscal year 2020, we compared those same programs' expenditures from state fiscal year 2019.
Okay, I think I understand. Okay, I'm going to go ahead and move on to some of our members who have questions as well. Representative Raymond.
Thank you. I think this is for Ms. Bell. I wanted to dig into neglect a little bit. I really was hoping that you would tell us what it looks like in a lot of these families. We hear very often that Kentucky's #1 for child abuse, and some of us may even use that statistic. But it's my understanding that neglect is built in there. And so, when we're comparing states, is it apples to apples? So if you could touch on neglect, how it factors in here, and in my understanding, it's also related very much to poverty, and it can be racialized. And I'd love to learn more.
Sure. So that is really a great question. And the answer is definitely that it's not apples to apples. There is actually no way to compare one state to another. That child maltreatment report that comes out at the federal level attempts to aggregate data, and it does come down to a rate of substantiation per capita. So looking at, the relative size of a state to the number of substantiations. But each state establishes their own statutory definitions of neglect, their own acceptance criteria. So what meets criteria for acceptance for investigation or acceptance or assessment in Kentucky, and what then results in a substantiation? Kentucky is entirely different from every other state. Each state is unique. So there's really no way from an empirical or research perspective to compare states and rank them like that. Kentucky does have the highest rate of substantiation per capita, but we also, a lot of national consultants describe us as having very wide open front doors. And I'm not saying that's necessarily a bad thing. I think what it says is that we care a lot about how children are treated in our state. And so the things like educational neglect is accepted for investigation in our state. It is not accepted in many other states. We also have very broad mandatory reporting laws. So for example, in Kentucky, it's universal mandatory reporting. Everyone is a mandated reporter. That is not true in other states. In other states, it's true in some other states. It's not true in all other states. In some other states, only professionals who work with children and families are mandated reporters. And so it's definitely not an apples to apples comparison. The other part of your question, yes, overwhelmingly of the calls that do meet acceptance criteria for us, and that result in a substantiation, overwhelmingly those fall into the neglect category. There are many different types of neglect. So we have neglect, as a result of inadequate supervision. We have medical neglect. There's environmental neglect if the child's home environment is not appropriate or doesn't meet their needs. But the smallest categories in terms of substantiation are physical abuse, even less sexual abuse, and then the last category that we don't talk about a lot is emotional injury. So in that order, but neglect is overwhelmingly the largest category of substantiations.
Okay, Representative Prunty.
Thank you, Madam Chair, and thank you for your presentation. Mine's a historical question. On slide 14, page 7, you talked about the new category of in-home care being with relatives. And some of what you presented seems like kind of common sense things that would make a difference, which are making a difference. Why wasn't that going on all along, or what was different? Was that being driven by federal funding or policy from Washington, or why wasn't that always the case, I guess? And you may not be able to answer.
I'm not sure. I'm not sure that I can answer. It goes back, a number of years in terms of our practices, but it was certainly a practice both by the Child Welfare Agency and by the courts that it was very commonplace for relatives to be given custody of those children directly. And many relatives still choose that today. I think the difference today between what was happening prior to April 1st of 2019 is that we have a written array of services or written array of options that relatives can choose from, that they can hold in their hand and they can see and have a very good understanding of what all their options are, from taking temporary custody of the child directly to becoming approved as a child-specific foster home, becoming approved as a basic foster home. And they understand the expectations and also the benefits of every one of those choices. And so we were not doing that well prior to April 1st of 2019, but now relatives are very well informed of all of their options so that they can make an informed decision in those first few days that a child is placed with them.
Thank you. Thank you, Madam Chair.
Senator Meredith.
Thank you, Madam Chair. And two questions, if I may. First, nice presentation. Did a great job. Kind of like drinking from a fire hose, but I appreciate the information. I was going to ask you, and you may have kind of answered this already, about the incident rate per capita, but you've already said that we can't compare ourselves to other states because the reporting requirements are entirely different. And I understand that. But are we measuring ourselves against ourselves? Is that the plan?
Yes, and that is I'm glad that you asked that question. That is a great use of that report that comes out from the federal level, is so that a state, assuming that there haven't been significant changes in statutory definitions of abuse and neglect, it is a great use of that report is for a state to measure itself against a previous year's performance.
Well, another reason I was going to ask that question is I heard the number 9,300 roughly kids. Just anecdotally, that seemed like a small number. So I was wondering about our capabilities to actually identify these cases. That's not a question, just an observation. I just thought it seemed low compared to Kentucky's historical position of having a lot of poverty, and that's obviously consistent with this type of situation. So that's something that maybe we need some further information on in the future. But last thing I have is on slide number 3, the child care funding and the update. We've got $293 million designated through one-time CCDF funds for increasing provider payments, improving payment policies, increasing wages, building supply of childcare, which I think is all great and certainly needed. But I am curious, have you given any thought to what happens after these funds are no longer available? How are we going to sustain that?
Yes, that was one of the first questions that was asked by many of us at the state level whenever the funds were awarded. So there are going to be some projects that are created that will sustain. Like one of the things that the federal government is wanting is us to change our technology and data collection system so that we will know exactly where enrollment is across the state, things like that. So those funds will be developed they'll be used for a one-time project and then be sustainable for a long term. And there are several projects like that, startup grants for new programs in childcare deserts or family childcare homes, and we won't need the startup funding again. Now, when it comes to subsidy and employee wages, those are things that we have to think about what happens long term. One of the things we're doing is collecting a lot of data through this process. As we ask the providers to fill out the contract and they get the 9 sustainability payments, they're also going to be giving us data on how those funds affect their turnover rate for staff, how those funds affect the number of children that are enrolled, and makes a difference on those issues long term. As we collect that data, that will be information that many of the states are using as we look to long-term infrastructure changes through the federal government with the funds that they're considering for childcare long term, as we present information to the state also. And then along with this, we also do have some of that funds that the very bottom of the slide that talked about childcare that Misty presented talked about smaller increases to our annual federal match money that is occurring with this also. So as some subsidy rates go up, we do have some match money that's increasing. Also, we were very grateful that we received additional funds from the state government this year for an increase in CCAP. So a lot of these projects are working together. Now, will we be able to match the exact same rates after this 2.5 years is over? I doubt that we will have an influx of money that's this large. At the same time, if we're talking about subsidy for families who need childcare and are at risk, would they rather have a higher rate and a break right now while we're rebuilding than us not put that money into subsidy and long term? If we're able to increase the rate quite a bit right now and families can rebuild and get back on a stronger financial footing, and then we do have to decrease it after a couple years, it still gave them a really needed break to get back on stronger footing.
I appreciate that. And just to kind of summarize what I think you told me is that by improving, for want of a better term, the environment of Kentucky and getting more families back to where they need to be, children back in the homes, that the realized savings of that can be used to sustain these increased payments for services. Is that fair?
That's fair. And then some of those projects will have a long-term difference that don't need continued funding to. And, with our data, with new startup programs in areas where there hasn't been access to childcare, that'll make a huge difference as well.
Thank you. Excellent explanation. Thank you, Madam Chair.
Mm-hmm. Okay, thank you. We have a question from Senator Berg.
Thank you, ladies, for a very detailed and interesting presentation. I don't know if we have these numbers, and if not, I'm going to ask you if you can perhaps estimate. But when we talk about neglect as being our biggest number in the state, do you all have a sense, or do we have the data, what percentage of that is poverty-driven, what percent of that is substance abuse-driven, and what percentage of that is mental health care in the caretakers driven?
I think that we can provide some data around the categories of neglect. It is hard for us to provide hard data around poverty because we do not routinely collect household income information when we do a child welfare assessment. But I think that there are categories of neglect that you can certainly see the link to poverty. A lot of times with supervisory neglect, neglect, it maybe the family does not have access to reliable quality childcare. There are areas of our state where there are childcare deserts that we still do not have licensed and certified childcare providers. So that's a real challenge for families. Environmental neglect very often is because of poverty. The families are living in structurally unsafe dwellings, for example. And so I think that, we do capture information in the narrative of our assessments that certainly speaks to poverty at times. But that is, again, we don't capture that household income information on every family for which we provide an assessment. So it's hard to provide that hard data. But poverty alone is not neglect, and that's one of the things that we really want to address. But poverty certainly creates risk for neglect if families are not able financially to provide for their children in the way that is expected. We do, so substance abuse in and of itself is not a category, but we do collect information about whether substance abuse was a case characteristic. So we are noting when we do those assessments whether substance abuse was present, whether it was a factor that led to removal of the child, so we can provide data on that. I don't know the data off the top of my head, but yes, we can definitely provide that.
Senator Alvarado.
Thank you, Madam Chair, and thank you all for your presentation. Just really quickly, one thing of interest to me is these high-fidelity wraparound services programs, which are very effective. Got a group in Mount Sterling, Gateway Children's Services, which wants to get into this field. I'm curious about the costs per child on that. I know they're very expensive, but I know that it's evidence-based data that actually works once you implement it. Mm-hmm. So I'm curious if you could comment on that, if I'm looking at how much money we're receiving. If we have roughly 9,300 kids, that's a lot of money per child. And if we've got evidence-based practices that work, if we applied it per child, that would be enough potentially to really make huge impacts in those children. So I'm curious if you could comment on, what that entails, how much money that would be roughly per child when you get those programs, if it's an annual cost, if it's a one-time cost, et cetera.
I think that is information that we can definitely provide in terms of an estimated cost per child. What I will say is of our existing array of evidence-based practices, high fidelity wraparound, if you put it in that existing array, is definitely not the most expensive evidence-based practice that we would be providing. A lot of the cost of our evidence-based practices under Family First depend on the credentials of the clinical staff who are licensed to provide those services, or who the credentials that they have to have under that evidence-based practice model. And so as compared to some of our other evidence-based practices, high fidelity wraparound doesn't require credentials that make the cost of staffing as high as some of our other evidence-based practices. But I think that we can provide some information to the committee about what an average cost per child would be for a high fidelity wraparound.
Yeah, and again, it's even if you could just educate the committee a bit on what those kinds of things entail. Because our group in my district are talking about $40,000 or something per child, so it's not cheap either. But if we've got about, by my calculations, about $92,731 we're getting assigned here for those 9,300 for each child, 9,300 kids. We're spreading it out in lots of different methods, but you've got systems that are proven that can work. You could really put a lot of that emphasis in there, and so that's why. But if you could expound as to what that would cover, what those high fidelity services are.
Sure. And so the high fidelity wraparound services, it really very often works in conjunction with other evidence-based practices. So what happens a lot of times when families are in need of services, they get referred to one provider for one type of service, to another provider for another type of service. What high fidelity wraparound does is it puts one case manager in charge of ensuring that a family has access to every service that they need and ensures that those services are occurring. monitoring. So it's really, it's largely based on case management services, not the provision of a specific type of therapy as some of our other evidence-based practices are. So most of the costs for high fidelity wraparound are in staffing, but the staff who are qualified to provide that service are from a personnel cost may not cost as much as some of the staffing that is required to provide other evidence-based practices.
The other thing, if I could, Madam Chair, kinship care, which obviously has always been a topic that we've seen here, at least since I've been in the General Assembly. Many of us I know support that idea, that concept. There's always a huge price tag on it. Have any funds been considered to at least expand the number of people that could get that, or do we have any kind of renewed price tag on what that would cost for us as a General Assembly per year? Because we have several families who have said, "Listen, I've already raised my kids. I'm a grandparent. I'd love to raise my I don't have any funds with which to do it. If you're going to put those kids into a foster care home, you're spending the money there anyway. Even if we gave them a percentage of that, they could probably afford to do that and keep it within their own family." So I'm curious if we have any updated numbers on what that would cost on a program to cover a lot of these kids within that setting.
So with the implementation of the new relative service array, that is actually one of the things that the information that's provided to relatives in the very beginning in terms of their options and what the benefits are associated with those options. So if a relative does choose to become approved as a child-specific foster home or a basic foster home or any other foster home type, if that child cannot return back to the birth family, the relative has the option to adopt that child to achieve permanency through adoption, and then an adoption subsidy that is equal to the foster care per diem is paid to the relative, the same as if a non-related foster family adopted that child from care. So that helps to support the child until they reach the age of 18, even after the child has already reached permanency. I know that there are relatives prior to the implementation of that new relative service array prior to 2019 that fall in that gap between the old kinship care and when the new relative service array rolled out. And I don't know what the cost would be to provide long-term supports to those, but that may be the population that you're asking about.
It'd be helpful to have, if you guys could provide that. I mean, ultimately, we've got a budget cycle coming up. There's always discussions, always priorities. And that's, budget ultimately becomes about priorities. But if we're wanting to focus on kids, that might be something that we might have an opportunity to do moving forward. So if you all could provide us updated numbers, would be great. Thank you.
Yes, sir. And in that line of thinking, before I forget, if we could really identify what sorts of barriers there are to getting kids into relative care versus into foster care, I think that would be helpful as well. Are there some things that we can do to incentivize relative care versus out-of-home placement in foster care? So we do have a few more questions. Representative Fleming.
Thank you, Madam Chair. Appreciate it. First of all, ladies, unlike some departments who's come before committees, I have most comfort in your handling of the data, servicing these children, and coming up with some answers that are very well thought out, and the way you handle things are very good. So I want to compliment you on your job well done in getting us educated. I'm still getting myself acclimated to all this, so I do appreciate all the information you provide. So kudos to all three of y'all.
Thank you.
I wanted to make sure the numbers that you threw at us, are there like I think on number 13, slide 13, I should say, you said all FFPS services, and you gave some stats. Are there any duplication of kids and families being served? I mean, in other words, you may have a couple programs. Are they being counted? No, these are all unique individual. Okay.
Yes. So those FFPSA services that are all compiled together on slide 13, the three major program areas under FFPSA are START, K-STEP, and our family preservation programs. And so there is not duplication. So if a family is being served under K-STEP, they would not also be served under family preservation. They're going to be under one of those three program areas.
Okay, the other question I have, when it comes to neglect of children, can you give me a geographical distribution of children and families in the state? Are they concentrated in one region or one area, or it's just evenly distributed? I'm just trying to figure out if there is a trend, and I think there's a comment a few minutes ago in terms of having poverty being associated with this, and I got an idea where more stressed areas are in this Commonwealth. But I just don't know if there's any type of distribution of that.
That's certainly data that we have. I can't tell you sitting here today that I'm aware of significant differences between regions in terms of how that breaks out when you think about neglect, physical abuse, sexual abuse, and emotional injury. I'm not aware sitting here today of significant differences by region, but that certainly is information that we can gather together.
And I would just add that the expansion of the programs that we mentioned are in target areas because we have seen a need in those areas. So that is why expansion is planned in specific areas.
Okay, well, thank you. Hopefully one last quick question, Madam Chair, and that is, you gave I guess a sort of 2 or 3 points. One of the points you made was you don't keep track of or have a good handle on emotional impact. Can you expand on that?
So what I believe what I said was the emotional injury is one. Yeah, emotional injury is one category under which we can substantiate. So the large categories are neglect, which is broken down into different types of neglect: physical abuse, sexual abuse, and emotional injury. So emotional injury requires the statement of a qualified mental health professional that emotional injury has occurred to a child. So one of our child welfare workers on their own could not draw that conclusion and substantiate emotional injury. It does have to be assessed by a qualified mental health professional. That is a small percentage of the reports that we get. It's the smallest category of type of substantiation of maltreatment as compared to the others.
Great, thanks for the clarification. Thank you.
Senator Howe.
Yes, thank you, Madam Chairman. Appreciate your time here today out of your schedules. On slide 14, talking about the commitments to the cabinet, there's lies, damn lies, and statistics all across everything. But we seem to see the uptake somewhere around February of 2018 of a significant increase in commitments. Is there any one particular thing that or combination of things that you've seen that are tied together to explain that increase?
I'm not sure that we can draw direct cause and effect. I think that there are a number of factors that influence that. I know that certainly there has been attention to the opioid epidemic for a number of years as contributing to the number of families coming to the attention of the cabinet and certainly the number of substantiations. And so I think that could be a contributing factor. But I'm not sure that there is one or two things that we would be able to say is a clear or direct cause and effect on that. But the general trend line is that out-of-home care number, had been rising for a period of years.
Right, but it had been more of a gradual, and then we saw a real uptake at that point.
Right. I don't know the reasons.
Okay. Thank you.
Okay, thank you. And then Representative Weber. No, you're okay. You're good. Okay. Well, I just want to thank you for this excellent presentation and for all of your work on implementing Family First. I know it's no small undertaking, and I just want to applaud you for the good work. I'm sure that questions will continue to arise, and we appreciate your partnership in working on any barriers that we might have. Okay. And also thanks to Jenna once again from NCSL. I do have a very quick question. I brought this up in a previous presentation, but we have residential agencies who are kind of waiting in the wings now with Family First being implemented. They're not exactly sure what their role is now. Has any thought been given to creating partnerships in really, rolling these professionals into helping implement some of the Family First? Because, it's not as though they're going away, nor should they. I mean, we may need them again. And I want to make sure that we're cognizant of that issue.
Yes, absolutely. And these are our valued partners, and they're very important to the services that we're providing to not just our children in our out-of-home care population, but many of them currently have also a continuum of services under their umbrella that they're also providing services to families in their homes. And you're going to hear from a couple of those later on the agenda. But we are having intentional conversation with those providers. We appreciate the services that they've provided. Many of our providers have been certified as qualified residential treatment programs. They have stepped up to meet all of those requirements and are providing very high quality services. We are, we know, going to, even though those numbers are going down, there is going to be a continued need for children in congregate care. And those QRTPs are stepping up to meet that need. But we are also having conversations about the need to provide services to families in their communities. And those providers are part of those conversations. There is also right now a request for proposals that is currently posted. And providers have been made aware of that opportunity to provide prevention services under Family First.
Perfect. Okay. Thank you so much. All right.
Thank you.
Thank you.
I think we are ready to move on now to our next agenda item, and that will be an update on child support changes in the 2021 regular session and on House Bill 404. I think everyone is in person, so just make your way to the table, make yourselves comfortable, and please introduce yourselves for the record and proceed.
Good afternoon, everyone. Chair Moser and Alvarado. My name is Steve Vino. I'm Commissioner of the Department of Income Support, Cabinet for Health and Family Services.
And I'm Lily Pattison. I'm the Director of Child Support Enforcement.
I'm Mary Sparrow, and I'm a Procedures Development Specialist.
We'll start our presentation. House Bill 404, for the most part, was an update to the child support guidelines. They hadn't been significantly changed since 1990. Fortunately, Chairman Ed Massey sponsored our legislation and got it through the process, and we have the new law now with more updated numbers, statistically valid. And I'll just go through some of the updates. Lily will talk about the regulatory implications. So first of all, KRS 403 to 11.9, we increased the extraordinary medical expenses. It made sense to do so to $250 from $100. It's been in place for a number of years, so that made sense to do. It wasn't a federal requirement, just a common sense thing. 403 to 12 2D, self-support reserve was added to the statute, and it was considered a subsistence needs of the payor parent with a limited ability to pay. In other words, when you order child support, you make sure that the individual that's paying the support has the ability to live, basically. So that is factored into the guidelines. 403.2.12 clarified that incarcerated parents were not found to be voluntarily unemployed or underemployed. That was a federal requirement, and that was included in the bill, and that was part of our original package. 403.2.12 updated the language defining a non-residential custodian basically as a parent. And 403-212-7 updated the guidelines tables. The table, that was the major thing we did in the legislation. We had an economist, worked with a lot of stakeholders throughout the Commonwealth, including the legislature, judges, and Child Support Enforcement Commission, Guidelines Commission, and was very good to have that because the past numbers were not really statistically valid. When you tried to drill down on what they were based on, it was hard to determine. Today's numbers are based on the economic standards of people in Kentucky at this point in time, and it's up to date. If we ever have to change it in the future, it'll be a really easy change to use statistical comparisons based on Kentucky's particular economic situation. We did extend the gross income to $30,000 to the uppermost reaches of the chart for parents that have a combined monthly income of $30,000 a month. Also, there was a new section created under 403, shared parenting, and how to determine obligation of each parent in each situation. This was some interest at Chairman Massey and Chairman Petrie, and a number of judges and private bar had interest in. So that was included in this bill. It's a delayed implementation. Chairman Massey is in the process actually of gathering stakeholder feedback and plans to submit changes to or input received from the stakeholders in the next session of the legislature. The implementation date of shared parenting is March 2020. I'm sure he'll have recommendations in the next session. 406-31, retroactively applying child support obligation 2 years from the date of the birth. Originally was 4 years. Thinking there, again, this wasn't a federal requirement, but thinking there was when someone is found to be the father of the child, to be more fair to only retroactively go out back 2 years as opposed to 4 years, as was the prior law. And one that's not listed on here is 620.090, and that was ordering child support in temporary removal situations. In other words, when someone is removed, child is removed and placed with a caretaker, the court is required to order temporary child support in those situations. And we'll move on with Lily.
And as a result, amendments had to be made to the regulation as Commissioner Reno went over several categories. The emergency regulation was signed on June 29th, 2021, updating the child support worksheet monthly obligation, CS 71 and CS 71.1. That worksheet focuses on non-custodial parents who are 100% of the monthly income. Instructions regarding the statement of income was also updated to be relevant to the unemployment and underemployment situation for incarcerated individuals. As you can see in the slide, the emergency regulation will have a public hearing if it's requested by August 23rd, and written comments through August 31st. For the ordinary regulation, those 2 dates would be September 27th and September 30th of 2021.
And our last slide regarding the new section of KRS 403, regarding the shared parenting credit. Again, I mentioned we'll be collaborating with Chairman Massey. We have some input. Of course, he's driving the meetings, and we'll seek out comment from the stakeholders. I mentioned the delayed start date regarding the method of applying credit due to each parent. So he wanted to hear from a lot of the stakeholders regarding that. There's different opinions in that area depending on what practice you're in. Child Support Enforcement Program is actively engaged with key stakeholders. Lily has worked with a number of the county attorneys on their issues. Also, we've heard from the Administrative Office of the Courts, from some judges, and we've sent them to Chairman Massey for consideration. So we look forward to working in that process, and that concludes our presentation.
Okay, thank you so much. This was helpful. I appreciate the update, and we have a question from Senator Alvarado.
I do. Thank you, Madam Chair. Can you guys give me an idea about how much money is currently in child arrearages right now, as far as throughout the state? I mean, I've been told it's a huge amount of money. I've been told Jefferson County's $80 million alone. So I'm curious what we are looking at as far as statewide and arrearages on child support.
I don't have that information available, but I can get it for you. But let me kind of clarify what encompasses that amount. So we don't handle the child support case from birth onward. So a lot of times when people apply for our services, there is already a substantial arrearage due. So when that person comes to us and becomes one of our child support cases, they could have a $25,000 arrearage, and then that incorporates into our total arrearages uncollected, but it doesn't necessarily mean we weren't able to collect it. It is a substantial problem, though, of uncollected arrearage across the Commonwealth, but we'll be happy to get you some detailed information.
I mean, I would think that's your role, right, to find out how much money there is. I'm surprised you don't have that data at the top of your head as to how much money is being owed in that. But if it's $80 million for one county, and I know Jefferson's large, it's going to be hundreds of millions of dollars. And that's what happens is when that doesn't get paid, then those children have to come to the state for support. And it adds all those issues. And we've got an administration that's been pushing to say, let's give people who aren't paying those funds, let's give them SNAP benefits and give them other kind of public assistance. And they have a responsibility to pay for those things. So I think you need to know those numbers at the top of your head as a commissioner to find out how much money is being owed in that. If it's $80 million for one county, I can imagine what it's like. And that just puts more of a burden on the system for others who may need those supports, because then those kids don't have any way of having any help, and they come to the state for that. So I would encourage you to get those numbers, have it off the top of your head if you come before a committee, to kind of know what those numbers are, because I know it's astonishing. But that's what I've been told is $80 million for one county. That's got to mean the rest of the state's going to be over $200 million. And I think we need to know that, because it puts quite a burden on other support services for us in the state.
And keep in mind the arrearage that we capture is from whenever the case comes into our system to when it leaves it continues to accrue. Even though they turn 18, we still keep those arrearages in our system even after they emancipate. So that's why it's hard to give you a detailed information on the total arrearage uncollected.
Okay, seeing no further questions, thank you for your presentation. I do hope that the arrearage issue is part of the conversation with Chairman Massey. I know that he's very in tune to these issues and is pretty creative. Maybe we can look at ways to give more support to our county attorneys who are tasked with collecting this the child support. So look forward to hearing more, but thank you very much for your update.
Pleasure.
Next, we have some folks here to talk about the multi-systemic therapy pilot programs. And I see my friends from the Children's Home of Northern Kentucky, and I think we have some folks here also from Home of the Innocent. So if everyone wants to make your way to the table, and you can figure out how you want to sit and introduce yourselves for the record. And I look forward to hearing your update. Okay, welcome everyone. Thank you for being here, and please proceed.
Good afternoon. I'm Paul Robinson. I'm the president and CEO at Home of the Innocents. Thank you very much for the opportunity to speak to you this afternoon about multi-systemic therapy. We'll just refer to it as MST to keep this even more brief. For those of you that are not familiar with Home of the Innocents, we are a 141-year-old organization that is committed to taking care of the children and families of our Commonwealth. We operate the state's only skilled nursing facility for medically complex children, and we are one of the largest providers of congregate residential treatment care in the state. As you've heard in the previous presentations, we are certified as a QRTP, and beyond those two items I just mentioned, we also operate a large array of mental health, behavioral health services that are rendered in homes, in the community, and really are beginning to expand to provide more and more preventative services. So it has been very important to our board of directors over the last several years that we revisit our business model and we really begin to shift to provide more preventative services. This came really at a wonderful time because in 2018, as you heard, at the federal level, Family First Prevention Services Act was passed. And at that exact same time, our board of directors was very interested in getting into preventative services because we really aspire one day to not exist. We would love to be at a point where no child comes into congregate care and there's no need for our services. That may sound odd, but we really truly want to help keep the children with their families. So in 2018, we began working with the Department of Community-Based Services and with MST to begin having discussions about how could we bring MST to the state and how could that fit into the state's plan to expand preventative services. At that time, no one in the state was licensed to provide MST, so we were really the first that were really working to champion that. And the reason that we selected MST is because it had incredible outcomes. Also because it was well supported on the California Clearinghouse. You've heard a little bit about that in the previous presentations. So we know that it comes with incredible outcomes and it is highly rated. And then we also, and I think Senator Alvarado, you mentioned the expense and the cost of getting into some of these evidence-based practices. I recognize that because we knew when we made the decision to get into MST, there was a $500,000 price tag associated with that, that most nonprofits are not in a position to be able to weather. We are very fortunate that we had large grant funding from several private grant funders that really provided us an incredible opportunity to jump into the service array, to pilot this for the state, and to help find a way to bring this to Kentucky.
My name is Lydia Bell. I'm the Chief Strategy Officer at Home of the Innocents, and I want to talk to you today a little bit about our experience starting the implementation of MST. We were able to, well, first of all, let me start talking about what the model is. The model empowers families and youth by working intensively to teach them skills and change behaviors. So this is not a sit in the office, talk about your feelings kind of therapy. This is an intensive 24 hours a day, 7 days a week, theoretically 365 days a year, though the treatment doesn't last that long, where our therapists are actually working with the families and the children in the very ecologies they need to be worked within. Because of the intensity of the program, MST can reduce delinquent behaviors, it can change antisocial behaviors, and it does so by viewing clients as parts of a larger system. Families and children don't act in a vacuum. Kids go to school, parents do or do not go to work. There's churches, there's community, there's peer groups. So all of those things are factored into the way the MST model is worked. Caseloads are kept very small due to the intensity of the cases. So each therapist will work with somewhere between, say, 3 and 6 families. The typical caseload is about 5 families. You'll usually only see the 6th coming on as a family is being discharged out of the program and they're ready to bring a new one in. Oversight, well, the ideal case length, by the way, is 3 to 5 months. Most cases will resolve within about 4 months, and I'll be able to tell you how many we've had in the year that we've been able to implement. Oversight is provided by an MST expert. So our MST therapy teams meet on a weekly basis with the MST expert. That is extremely essential to the fidelity to the model. Our teams are comprised of a lead therapist who supervises the team, and then 3 to 4 therapists. Our current team has 3 therapists and a supervisor. And then again, that MST expert becomes part of the team as well. So let's see. The criteria for children who come into the program, we are looking at youth who are ages 12 to 17. They are chronic or violent juvenile offenders. They tend to have multi-system issues, so they may be involved with DCBS and also DJJ. They may have no involvement with either of those systems, but we know that involvement is imminent. They may also be transitioning back home from either a DJJ placement or a DCBS placement. So a child coming out of congregate care who's going back home to a parent, this may be a perfect way to get them back into the home and have them stay there. Again, because it works with the entire ecology of the child, including the parents. The model does allow for children in foster care where the foster parents are interested in doing multisystemic therapy to have that happen while the child is in placement. However, currently due to FFPSA and DCBS, we cannot put children who are in paid placements into MST at this time. Hopefully we can change that at some point. Another exclusion or another criteria for being a part of the program is that less intensive treatments have been ineffective. For children who cannot be served by, we do have exclusion criteria. There are some children for whom MST will not work. Kids cannot be served by MST if homicidal, suicidal, or psychotic events are the major thing, unless those crises have been averted and abated. Youth who live independently cannot be served. They must be living at home with a family. Sexually reactive youth, where the sexual, in the absence of other delinquent behavior. So if sexual reactive is the only thing going on, they would be excluded from the program. Youth whose issues stem from disorders like developmental disorders like moderate to severe autism spectrum disorder, or youth for whom intellectual disabilities are the primary causes of problems. There is an ability to learn and engage in the material that has to happen. MST really starts with several assumptions. It starts with the idea that the family is the solution. We approach things from the attitude that the parents are the experts in their children. Our therapists are the experts in behaviors. So we don't give up on families. That is not an option in MST. And part of what becomes really crucial for the MST teams is that they are creative and they are working on how to engage those families throughout the entire process. And if you can think about an intensive 3 to 6 month process of having to reach out to your therapist multiple times a week, it becomes crucial that the therapists be really good at keeping the families engaged. So our therapists become really good at doing that really quickly, and I'll show you a slide in just a moment that can show that. We know that parents want what's best for their children regardless of the situation. We also believe that families and communities need to be seen as partners in trying to keep these families together. We always joke about it takes a village. We joke about that at the home because we built a village. If you've ever visited our campus, you could see that. But it is true that you cannot take a child out of a situation, work on the child and put them back in that situation and expect that things are going to change. So MST, again, multi-systemic therapy, really looks at those large system changes that incorporate the family, the community, the child. So our therapist might be with the football coach, teaching the football coach how to have a more positive influence over the kids that he's coaching. They might be with teachers talking about how to engage the parents in this family to ensure that the child is inspired. There might be reaching out to a supervisor at a job if the child has a job. Again, these are 12 to 17-year-olds. That's totally possible. So it's really, these therapists are getting into anything and everything that they can. Changes can occur quickly. When you engage the family in multisystemic therapy and they engage in the work and they do the work, 4 months is really doable to make these changes happen and to make them stick. In the previous slide, we showed a lot of the outcomes that come from MST, they can show over a period of months or years post-discharge from the program. We also believe that science and research can provide valuable guidance on how to move forward. Evidence-based practices, these practices work, and so we continue to stick with things that do work. The nice thing about multisystemic therapy, if trauma-focused cognitive-based therapy isn't working, maybe we can try motivational interviewing. Those are both two evidence-based practices that can be incorporated into the MST model. This slide shows you some of the outcomes that we've had. Now, we were able to start actually seeing clients on July 2nd of 2020. So we do have exactly 1 year of data to share with you on what's happened. I also want to take this time as I go through the slide with you. I'm going to talk about some of the lessons that we've learned in our first year of MST implementation as well. So you can see the greens, the yellows, and the reds, and these are exactly a stoplight report. So this tells you where we're hitting targets and where we're not. And I've pulled this report completely off something called a PIDER report, which is a report that our team does every quarter with our MST expert. We have certain targets that we have to match for an entire list of client-based outcomes as well as compliance-based reporting for our team and how they're implementing the model. What I have with you today are the client-based outcomes that we're focused on. So overall in our program, we have served 37 children. I know you don't see the number 37 on this chart, so I'll explain that. 24 of those children have successfully discharged from the program. 7 of those children are still in active treatment in the program. 6 of them were discharged for either an administrative reason, meaning we got into it and realized that they didn't meet the criteria. Lack of engagement, no matter what our therapist tried, they could not keep the family engaged, or because of an early placement, which made them no longer eligible for the program. I will tell you, out of those 37 kids, we only had 2 kids who ended up going on to a placement. So you should look at these 37 kids as 37 potential could have been in out-of-home placement in a congregate care setting through the state, but instead have been in MST. You can see in that first quarter we had, in the first quarter of data, it takes a while to get the team going. You have to hire the team, you've got to train the team. So we were really only able to onboard 1 client in that first quarter. We hit some pretty good targets there. Our average length of stay, we try to keep that average length of stay between 100 and 120. We did have to discharge this child for lack of engagement. Those 2 outcomes are red because we did not meet the targets on those. You can see that in the second and third quarters. The second quarter, we're kind of wobbly there. We're starting to see more yellow in the third quarter, but by the fourth quarter, we're really starting to hit a stride. There are a couple of things that reflects. One, it starts to reflect, if you will look at average length of treatment days, you're starting to see that trend line go up. We are able to keep those families engaged in the program a lot longer. You will also see that we had 9 out of the 10 kids who were in treatment during that last quarter who successfully made it through the program. You will also see that every one of those targets that we look for the clients were hit in that fourth quarter. It takes a long time to get that momentum going in MST. It is an extremely difficult model. It's very team-based. Again, the team has to be available to the client 24 hours a day, 7 days a week. So some of the lessons that we've learned, number one, it takes a long time for the team to hit that stride. Staffing is an issue. It is not the kind of model that every therapist in the world wants to go out there and do. Because it's the 24/7 intensity, it takes a special type of person who really wants to do that work. It takes someone willing to engage and do whatever it takes to get the family to stay successful in the model. Turnover can be a huge issue. What you see in these numbers reflects 2 team members that we had that we lost in the middle of our first year. We are very stabilized right now, but at that time we had a lot of turnover happening. We had to let go of a supervisor, and then we also had another therapist who left. We have since replaced the supervisor and have an amazing supervisor. Another interesting thing about MST, when you do hiring for MST, it's not just your own HR department. You have to work with the MST Institute to hire people. They put them through role play. There's a 4-interview process that has to be done with MST. It can take 2 months from the time the application is placed until you hire someone. And then there's a lot of intensive training that comes on after that. As an example, we hired a new therapist in June of this year. She will be ready to see clients the first week of August. It's taken her that long to get ready and get onboarded. The other lesson we've learned is that our therapists really need to be creative to keep these families engaged. If the therapist wants it more than the family does, it's not going to work. We do believe that we're going to continue to hit our stride. MST will never be something that hits tons of people at one time. Each team will do maybe 45 cases a year. We do feel that it's pretty good that we made 37 cases in our first year, especially during a pandemic. But we do feel that we are definitely ready to move forward.
So as we wrap up our portion of this, it's also important to note that because of the intensive nature of the care that is being provided, MST does limit us to a 90-mile driving radius around where we are operating. So for us, we are domiciled in Louisville. So beyond Jefferson County, on the slide here, you see the 18 counties that we are currently equipped to be able to serve. This does not preclude other providers from getting in and being able to provide MST. It is actually the hope that more providers will come on board and more people inside of these counties will be served. We do hope to expand from our current first team to a second team this year, on our way to a third team. The third team is slated to hopefully be out of our Hardin County office that is located in Elizabethtown, which further expands our ability to reach additional counties as well. We look forward to partnering with others that are going to be providing service, and that's a great transition to Children's Home of Northern Kentucky as they talk to you a little bit more about MST.
Thank you so much. I'm Crystal Loigers. I'm Chief Programming Officer at Children's Home of Northern Kentucky. I'm so grateful for the presentation. It was so incredibly informative. And as mentioned, CH&K is going to be relatively new to multisystemic therapy, but what we're not new to is prevention services. So in 2019, we initiated a contract for the provision of family preservation program. Through that, we were able to provide a number of evidence-based practices, one of which is functional family therapy. We've served 141 families, so a number of clients who have been served through that. Functional family therapy is a slightly less intensive model than multisystemic therapy. And so as we were evaluating the needs of the region, we felt like it was really important in our desire to have a full continuum of care to have a slightly more intensive model than functional family therapy, but to prevent out-of-home care and also juvenile justice involvement for the families that we're serving. So functional family therapy is specifically targeting families with children with slightly lesser crimes, as mentioned by Home of the Innocents. Multisystemic therapy, there might be a number of more serious offenses. Also, when we're looking at a family or a child who's particularly oppositional, there's a lot of defiance and resistance in the system. Sometimes that child ends up in residential care because of engagement concerns, but multisystemic therapy is a really great antidote to that in the prevention of residential or juvenile justice involvement. So we've submitted a request for a pilot program. We've actually just started meeting with our MST expert, which has really been a great learning opportunity. We're currently recruiting for that, but feel like it's really going to be a nice natural extension of our existing continuum of care. Like Home of the Innocents, we're also QRTP certified. So MST is going to be one step down from our QRTP and one step up from our family preservation program. And really important, I think, for the Northern Kentucky community to have access to this so that we can continue to prevent youth being placed in congregate care.
Okay, well, Rick, did you want to say anything or introduce yourself for the record? Maybe since you're sitting at the table, it's great to see you. Thank you for coming down.
I appreciate the invitation, Representative, and it's a pleasure to join this great body. I think you see the theme here, right? Mm-hmm. Since the 1800s, Children's Home of Northern Kentucky has been serving some of Kentucky's most vulnerable youth and families, and we have to do that in different ways. In the 1800s, Kentucky needed us to be an orphanage, and we did that work. And in the 1980s, we switched gears and we started taking care of kids who were in out-of-home care, who were in custody of the state. And over the last few years, similar to what Paul has been describing, it's the whole secret to success if we're really going to be serious about ending child abuse and child neglect in Kentucky. We have to move these services upstream. And so starting around 2014, 2015, we really spent a lot of time and energy and money investing in these outpatient services. And in fact, our outpatient services at Children's Home of Northern Kentucky had actually outpaced our residential services, even though we have two types of residential services: psychiatric residential treatment facility license and that type of care, as well as private child caring for the state. Even though we were doing well with those residential services and providing flagship care, it really was clear that outpatient was going to be needed to expand in Northern Kentucky. And if it had not been for the pandemic, we would be well ahead of where we are right now. But one of the major obstacles, I see that one of your agenda items was to talk about the impact of COVID-19. When our school partners, which constitute our largest referral partners in Northern Kentucky, when in-person instruction ceased, the number of kids that we were seeing dried up. It really presented some major opportunities to be creative and to be relevant. Fortunately, we had a donor who provided around $500,000 for us to grow our computer hardware, our computer software platforms, and we have been able to offer over 6,000 unique telehealth services in our outpatient arena. So I think the theme there is, how do we continue to be relevant as children's homes? And that relevancy right now is causing us to pay attention to expansion of family preservation programming and now the launch of multi-systemic therapy. We're going to follow the lead of our colleagues at Home of the Innocents who've blazed that trail in Kentucky, and it's a pleasure to share the table with Home of the Innocents.
Well, thank you so much. I really appreciate hearing from both of you and your organizations. I know what great work you both do, and it is important that we continue to hear about how you are working to remain relevant and really reach those families and reach the kids where they are and really address what they need. So thank you for what you're doing. Thank you for being involved in the pilots. It's great to it's always great to hear an update on some of the newer programming, and this makes complete sense. I really applaud your work. I don't know that we have any questions from the committee. I know that we've got a couple of other committees going on simultaneously. So, but I sure appreciate your being here and all of your great work, and I look forward to continuing the conversation. Thank you.
Thank you.
All right. Having no further business, I will thank you. We have a motion to adjourn. The next meeting, I guess I should say, is at the Kentucky State Fair in Louisville on Thursday, August 26th, excuse me. It is at 8:30 in the morning. I know that's super early, but we want everyone to be able to take advantage of the country ham breakfast, I guess, that morning, and then come over and talk about health and welfare. So thanks very much, everyone, for being here, and we will see you August 26th.
It's been a big That's for sure.
It's a great idea.
Guys, I just want to thank you all. I'm Karen Berg. I'm one of the student senators. I have a niece, actually, who was under custody and ended up in
This looks like this is a colloquium coming to work. So I'm going to meet my family. Have some dinner. One of my nieces is from Boston.
She was. I mean, she would have been dead. She would have been dead. There's no question about it. It was kind of before Christmas. But I just want to tell you all, I know firsthand what type of work. If you ever need my support, been down your campus a million times. I mean, I was the only family member who was allowed to supervise visitation. So you see? Oh my God! I mean, first of all, I drive past it on my way home from the hospital every day. Second of all, I've been there a million times. Third of all, I give you all money, but I just want you all to know. You saved your life. You saved your life.
That's one of our favorite things is when we hear stories like that. That's why we exist.
Well, it was the judge saying, you know, she's a good child. I mean,